Don't worry, Oriol comparison is a good comparison, thank you. Okay, thank you. It's the meeting for inviting me another year with you. This is the second cases. For today, I don't have disclosure. And this is our patient for today. He called Fatima, has a 24 years old female, BMI 77, and he has a renal colic 2 years ago, but they don't have the stone for make the analysis, and no relevant comorbidities. Last year, she started with acute left flank pain, radiation to groin associated with nausea and no fever. It's a classic presentation of a renal colic. In the emergency department, makes a blood test with normal renal function and hematuria in the urine analysis and crystal from calcium oxalate. We performed a non-contrast CT scan, has a 9 millimeters distal ureteral stone in the left side, density 1100 Hansfeld unit and mild hydronephrosis. The stone is very, very near to the bladder, so we choose a medical expulsive therapy with anti-inflammatory pills and tamsulosin. She has good luck, very lucky girl, and spontaneous stone paces from 1 centimeter stone. And we performed a stone composition was calcium oxalate monohydrate 90%. So the emergency department finished his work and start our work because it's a young patient with a recurrent stone disease, so we need a complete evaluation to prevent the recurrence rate. The metabolic evaluation with dietary history, blood test, and 24 hours urine. The dietary history is a very common classic Spanish young girl with a lot of vegetables and chocolate in her main day. And she doesn't like to drink fluids, especially milk. We performed the 24 hours urine and we saw a low volume of urine, only 1.1 liters, and elevated oxalate, a little below the citrate, and normal calcium, sodium, and phosphate. Additional blood tests with PTH and vitamin D discard the hyperparathyroidism. So the diagnosis is, I think, easy with a recurrent calcium oxalate nephrolithiasis, with hyperoxaluria, mild hypocitraturia, and likely dietary etiology is an enteric hyperoxaluria. And enteric hyperoxaluria increases the intestinal oxalate absorption with increased urinary oxalate excretion, with reduced citrate levels, so we have a urinary supersaturation with crystal formation. We have to make a decision for a treatment, and our initial treatment is the dietary changes in her life. No? Increased fluid intake, normal calcium intake, you told us before, and moderate oxalate restriction. And we prescribe a potassium citrate in low dose. We perform the follow-up between 3rd and 6th month after, in this case in the 4th month after he started the treatment, and he's very happy because he increased the urine volume, decreased the oxalate, and increased the citrate with no recurrence in the ultrasound. After the first follow-up in between 3 and 6 months, always perform 1 year after start the treatment, and 1 year after start we saw a very good urinary volume, close to the 2 liters per day, normal regularization of oxalate eliminated per day, and normal citrate, so we don't increase the potassium citrate. After the first year, when we obtain these results, we often perform one 24-hour urine every year, one per year, because it's very young, and our thoughts, if you don't stay with the patient normally forgot the recommendation. So the key message of this case is hyperoxaluria is common and sometimes underdiagnosis. Diet plays a crucial role, so we have to ask for diet, and metabolic evaluation is essential. Thank you.